So yeah, Assalamualaikum and very good morning to doctors and my fellow friends. So today we, Group 7, going to present regarding the chronic liver disease. Next slide, please. So this is the outline for our presentation today. Next slide. All right. We touch first with the definition, chronic liver disease. The liver disease itself is basically defined as a progressive destruction of liver parenchyma which leading to the fibrosis and the cirrhosis of the liver. The word chronic, subacute, acute is basically referred to the time course of the disease. So in the chronic liver disease, basically, there will be continuous progressive destruction of liver parenchyma more than 6 months, and followed by the subacute within the 3 to 6 months, acute below than 3 6 months. Fulminant disease is basically a very acute and severe, which the progressive destruction occurs within the 6 weeks of the onset. Now move on to the epidemiology. Uh, During the 2017, there were 1.5 billion persons suffered from the chronic liver disease. So in this slide, we already divided into the etiologies. The biggest contributor etiologies towards the chronic liver disease was non-alcoholic fetal liver disease, which accounts for 60%, followed by the Hep B virus, Hep C virus, and alcoholic liver disease. Next slide. So this is the etiologies. We can simply divide it into the most common causes, less common causes, and inherited causes. So as I said, the most common causes will be the viral infections, either HBV or HCV, followed by alcohol abuse and non-alcoholic fetal liver disease. It's basically referred to the metabolic syndromes. And also less common causes could be autoimmune hepatitis and etc. etc. So for along throughout this presentation, we're going to a little bit emphasize on the etiologies that has been highlighted with the red color. Next slide, please. So this is the study done at the University of Malaysia Medical Center from 2006 to 2009, which involved 460 participants. So from the table on your right is basically the illustrated from the study result. We can see that the biggest contributor etiologies that contribute to the chronic liver disease in the study is a chronic Hep B infection, which accounts for 46.1%, followed by the chronic Hep C. Cryptogenic is basically referred to idiopathic etiologies, most probably referred to the non-alcoholic fatty liver disease, followed by alcohol, and last but not least, autoimmune. And from the study also, we can see when the result being classified according to ethnicity in Malaysia, we can see that the China has the highest prevalence in the Hep B virus, where Malaysia has the highest prevalence in Hep C virus, and Indian has the highest prevalence in the alcohol abuse, which contribute to the progression to the chronic liver disease. Next slide. So move on to the risk factor. Risk factors basically highly related to the etiologies of the chronic liver disease. For an example, like exposed to body fluid and infected blood is most commonly among the healthcare professions, sharing infected needles and syringe, having unprotected sex with multiple sex, basically more commonly in the Hep B virus and Hep C virus infection. Excessive alcohol consumptions, more onto the alcoholic liver disease, obesity, and other metabolic syndrome focus on non-alcoholic liver fatty disease, and while chemical toxin exposure and certain medications refer to the drug-induced hepatitis. Next slide, please. So we move on to the pathogenesis. I'm going to briefly explain regarding the pathogenesis according to the etiologies. So first one, we're going to focus on the Hep V. So as you can see, the diagram show is the hepatocyte, the liver cells. The NTCP is basically receptor that where the Hep B can bind to it. Once it bind to the once it bound to the NTCP, it will be undergo endocytosis, and it will invade the inside the hepatocyte. Inside the hepatocyte, this Hep V will release the genome, and this genome will be invade the nucleus of the hepatocyte, And with the presence of the Hep B polymerase, also the host protein repair activity, this genome will be integrated into the host nucleus to form the cccDNA. So the cccDNA will be transcripted by the host RNA polymerase to form the pgRNA. So what happened here is the pgRNA, some of it will go to the ribosome and the rough endoplasmic reticulum to be translated to form coproteins and also the polymerase protein. And some of it will be reserved for the reverse transcriptase. All right. So the presence of the polymerase protein will catalyze the reverse transcription process where the pgRNA will recombine with the coprotein to form a new HBV virus. All right, the new HBV virus will be transported out through the cell through the ESCRT pathway, and some of the coprotein also will be presented on the surface of the hepatocyte. All right, this coprotein will be presented by the HLA class 1, and the HLA class 1 will trigger the infiltration of cytotoxic CD8 T cell, which subsequently will cause the lysis of the cell, the lysis of the hepatocyte. So the lysis of the hepatocyte will expose all the organelles, and these organelles are highly subsequent to induce the inflammatory reaction. So this is what happened during the heavy virus infection. So I'll stop at the phase of inflammation. Uh, Next. So all right. So for this diagram is more focused on the Hep C. So what happened during the Hep C infection is just take a look at this receptor. LDLR is lower density lipoprotein receptor, and also the heparin sulfate proteoglycan receptor. This receptor is where the Hep C will bound. So once it's bound to it, it will be like Hep B endocytosis into the cell. What the difference between Hep B and Hep C is, Hep B is double-stranded. So it need to integrate with the host DNA to be transcripted. But Hep CV is a single-stranded. So instead of combining or integrate into the DNA, it is directly goes to the rough endoplasmic reticulum to be translated. So the translated product will be RNA intermediate. This RNA intermediate will acting as a template. When this template being translated, it will produce a coprotein, and also will produce another PGHCVRNA, progeny HCVRNA. See, this PGHCVRNA will combine with the coprotein to form a new HCV virus, and some of it will reserve for another RNA replication for form a new HCVRNA. So when this HCV keep on replicating, it will be detected by the Kupffer cells or a local macrophage, and also our hepatocytes will start to produce inflammation formation. Inflammation formation is basically referred to the multi-protein cytoplasmic complex. This cytoplasmic complex basically is highly sensitive in detecting viral pathogens through its NOD-like receptor. So once it bound to the HCV, what happens is this cytoplasmic complex will release pro-inflammatory mediators such interleukin 1 beta and interleukin 18. So as the time goes by, constant induction of pro-inflammatory production, they will be promote intensive recruitment of the immune cell into the liver, and eventually will induce the inflammatory responses. So I'll stop at the inflammatory phases. Next slide, please. So let's move on to another etiology, which is the alcohol. So how much alcohol is dangerous. So basically, there are terms called binge drinking. In binge drinking, the blood alcohol concentration in the blood will be more equal or more to 0.08% or 0 to 0.08 gram of alcohol per deciliter of blood. All right. If this reading being achieved, it means that the alcohol being abusively consumed. This reading can be achieved if a male adult consume more equal or more to 5 drinks per day in male or 4 or more in female. So what happened? Liver is the main center, metabolism center for the alcohol. So in the liver, what happened is the alcohol will be metabolized to the acetaldehyde by the alcohol dehydrogenase. And subsequently, the acetaldehyde will be metabolized to the acetate by the acetaldehyde dehydrogenase. Both this process needed the reductions of NAD to NADH. So what happened at the end of the process, there will be increased NADH ratio to NAD. So what the important is, NAD is highly crucial for uh, initiate the fatty acid oxidation. If they were depletion in number, there will be reduced fatty acid oxidation and will increase fatty acid synthesis. This condition will lead to the accumulation of lipid in the liver and called as steatosis. Steatosis meaning there are fat or lipid accumulations in the liver. At the meantime, all right, when there's a highly abusive consumptions of the alcohol, our liver will activate another pathway to metabolize the alcohol, and it is called as a microsomal enzyme oxidation system, MEOS. All right, MEOS, MEOS, MEOS will take place in the smooth endoplasmic reticulum. So what happened is during the metabolisms in the endoplasmic reticulum, there will be the usage of CYP2E1 enzyme. It's basically one of the cytochrome P450 enzyme. By the activation of MEOS, there will be increase in the synthesis of reactive oxygen species, lipid peroxidation, mitochondrial glutathione depletion, and all of this uh, higher the higher percentage of reactive oxygen species somehow can cause the cell damage to the hepatocyte. Again, when the cell is damaged, it will be lysed and the organelles will be exposed to the surrounding, and these can infiltrate the pro-inflammatory response by our immune system. And from the steatosis, when the liver being inflamed, it will change to the steatohepatitis. In this case, we call as alcoholic steatohepatitis. All right. Uh, so in other words, we call it inflammation of the liver due to alcohol consumption. I'll stop at the inflammation phase. Let's move on to another etiologies, which is non-alcoholic fatty liver disease. For these etiologies, the best way to explain about it is using the two-hit hypothesis. I'm pretty sure all of you already heard about the two-hit hypothesis. So the first hit hypothesis is basically already occurs in someone who has high fat diet, inactive
You have 2 more minutes, sir.
all right, inactive lifestyle. So all of these can cause the first hit, which is the fat accumulation in the liver, also known as steatosis. So in this steatosis, the fat adipocyte tissue will be inflamed. Inflammation adipocyte tissue will release the pro-inflammatory inflammatory cytokines, which lead to the increased de novo synthesis of lipid in the liver. So excessive accumulation of lipid in the liver will cause a lipotoxicity. This lipotoxicity basically gives the second hit to the liver, which changes the the condition from the steatosis to the steatohepatitis, which is also inflammation. Next slide, please. So the last etiologist will be drug-induced hepatitis. How it affects a human is basically based on two pathway. It's either predictable or unpredictable. So I just move on to the predictable. For an example, acetaminophen. All right, 90% of the paracetamol will be conjugated in the liver to form a non-toxic metabolite, and 10% will be oxidized by cytochrome P450, which is later on will be conjugate with the glutathione to form a non-toxic. But what happened in the high dosage, there will be glutathione absent. And this intermediate metabolite known as NAPQ1 is highly reactive, and which can promote the cascade of oxidative damage. So the oxidative damage, free radical will induce inflammations and the cell lysis. So later, at the end of the day, the hepatocyte will be inflamed. All right, next slide, please. So what happened during the inflammations, if you can able to stop the etiologies, this liver, the inflamed liver, can return to the normal one. But what happened in the chronic liver disease, the destruction progress.
How many more slide do you have?
This is the second last.
Okay, finish this one. Next presenter.
All right. What happened is when there are progressive inflammation and destruction, uh, it will activate the stellate cell in our hepatocyte, which the stellate cells basically responsible in the formation of a lot of collagens. So a lot of collagen deposition will lead to the fibrosis, and the fibrosis lead to the cirrhosis. This is the state where not reversible, or also known as the end stage of chronic liver disease. Okay, that's all from me. I think that's all. Pass the presentation to the next presenter. Thank you.
Okay, next I'm going to present the topic of pathophysiology of the sign and symptoms and also the major complication of the chronic liver disease. Okay, next. Okay, so here are the symptom and also clinical sign, or we call as stigmata of the chronic liver disease. So for the symptom of the patient will come to you and complain about the right hypochondriac pain, abdominal distension, which is due to the ascites, ankle swelling, which is due to the leg edema, and then hematomesis and melena due to variceal hemorrhage, pruritus, which is the itchiness, breast enlargement, decreased libido, and loss of the pubic and body hair in men, infertility and amenorrhea in women. Confusion and drowsiness will happen when the patient develop hepatic encephalopathy. And then for the stigmata, you can see in the picture, but I will explain more in the next slide. Okay, next. Okay, for the stigmata of chronic liver disease, the first one on the hand, there will be a presentation of the leukonychia. It is leukonychia. It is an abnormal whiteness of the nail, either total, in spot, or streaks. So in the first picture, it shows the presentation of the leukonychia striata. It is in streaks, and the second picture shows a terry nail. Terrine is actually when the nail bed is entirely white, except for a small band uh, of pink or brown at the tip. And the second sign is the clubbing. So for the clubbing, up to 1/3 of patients with cirrhosis present with clubbing in case of chronic liver disease. As we all know that in clubbing, it increased curvature in all direction and it loss of the angle between the nail and nail fold. And the next one is the palmar erythema. For the palmar erythema, we also call it as liver palm due to the estrogen excess, and it is a redness at the tina and hypotina eminence with sparring the central portion of the palm. And normally it is in the non-alcoholic liver disease. However, in certain cases, the sole of the feet can also be affected. Next. Okay, next for the hysteresis, which is the hepatic flap, we need to detect for the motor disturbance by jerking irregular flexion extension movement at the wrist and metacarpophalangeal joint. So in order to do this examination, first we need to help patient on extend, and then we ask the patient to dorsiflex the wrist and we push the palm of the patient So we can see whether the hand is flapping or not. So normally it is a presentation of the hepatic encephalopathy, renal failure, and also carbon dioxide necrosis. And then for the next one is the Dupuytren contraction. For the Dupuytren contraction, it is associated with the alcoholism. So it is actually visible and palpable thickening contraction of the palmar fascia. So it will cause shortening of the palmar fascia that will lead to the flexion deformity of the fingers, and it involve the ring fingers and often bilateral. So for the face, you can see the pictures. This is the presentation of the jaundice, where this yellowish of the skin and sclera and also mucous membrane. So it is due to the hyperbilirubinemia and deposition of the bile pigment, and it is common in chronic liver disease, alcoholic or non-alcoholic liver disease. Okay, the next one is the xanthelasma. Xanthelasma, we can see the yellowish plaque on eyelid or in inner eyelid. Yellowish plaque is an intracutaneous yellow cluster deposition and commonly presented in primary biliary cirrhosis. Okay, next slide. So for the feta hepaticus, it will give offensive odor of breath with a sweet and pungent smell that characterized as hepatic disease. So next one is the parotid gland enlargement. For the parotid gland enlargement, it is bathed behind masseter muscle and in front of the ear. In order to check for this sign, we ask patient to clench teeth to palpate the masseter muscle. Usually, it is common in alcoholic liver disease. Okay, the next one is on the chest. There is sign of the spider nevi. For the spider nevi, it is actually a vascular lesion of the central arteriole surrounded by many small vessels. And the distribution of the spider nevi is at the area which is drained by the superior vena cava. And this spider nevi, we can see at the arm, neck, and chest wall. And the number and the site correlate with the severity of the liver disease, and the number may be increased or decreased as the patient condition changes. So the next one is the gynecomastia. Gynecomastia is the excessive development of the male mammary glands. It can be unilateral or bilateral enlargement of the breast tissue in the male, and it may be tender. Okay, next slide. Okay, for the abdomen, we can detect for the ascites where it is actually an effusion and accumulation of the serous fluid in the abdomen peritoneal cavity. Next one is the caput medusa. For the caput medusa, around the umbilicus, there will be dilated cutaneous vein, and as for systemic vein, normally it is vein of anterior abdominal wall, and for the portal vein, the paraumbilical vein is involved. And then for the hepatomegaly, we know that it is an enlargement of the liver. So we need to detect or increase in liver span with palpable left lobe of the liver. Next slide. So for the splenomegaly, it is enlargement of the spleen where we need to know the spleen enlarged in inferior anteromedial direction. So splenomegaly, it is indicate presentation of portal hypertension. So it is common in non-alcoholic liver disease and cirrhosis. So the next one is the venous hump. Venous hump is actually a murmur with continuous low pitch and soft murmur, and we can hear at the epigastrium. And then next, we also need to check for the patient testis to check for the any testicular atrophy. And the last one, we need to check for the leg edema, where there is a abnormal accumulation of the fluid in the tissue at the lower extremity, and it is common in the primary biliary cirrhosis. Okay, next. Okay, this is the pathophysiology of sign and symptom that I mentioned earlier. I think you guys can read by your own after this. Next slide. Okay, for the complication of the chronic liver disease, the first one is the esophageal varices or variceal hemorrhage. So it is caused by the portal hypertension. Portal hypertension may lead to the development of the swollen vein, which is called as varices. And when the varices rupture and bleed, it can lead to the variceal hemorrhage, which the patient will show the symptom of the hematemesis and melena. And next one is the ascites. For the ascites, it is also due to the portal hypertension, which will increase hydrostatic pressure in abdominal capillaries, and the fluid will exude from plasma into the from plasma in capillary into the peritoneal cavity. So patient will complain about the abdominal distension and also shortness of the breath. For the SOB, it is occur in ascites due to increased pressure on the diaphragm, and the fluid will across the diaphragm, causing the pleural effusion, and the patient lungs will become affected, and this will cause the SOB. Okay, for the third one is the spontaneous bacterial peritonitis. This is due to the infection of the ascitic fluid. So the patient that already developed ascites would have the chance to bacterial infection. So patient will complain about the fever and also the abdominal pain. And then for the fourth complication, next. For the next complication is the hepatic encephalopathy. So for the pathogenesis, it is impaired liver function and shunting of blood around the liver, causing the portal vein ammonia are not clear, and this lead to the hyperammonemia. And this ammonia, this will interfere with the brain function that then will cause hepatic encephalopathy. So patient will complain with the sleep disturbance, mood or personality changes, and also trouble in concentrating or thinking clearly. And the next one is the hepatorenal syndrome. When there's a renal failure in patient with advanced liver disease due to the reduction in renal perfusion because of the hepatic injury. So the pathogenesis is portal hypertension will cause systemic and splanchnic arterial vasodilation, and this lead to the underfilling, and activation of the hypertension will induce the vasoconstrictory system, RAS, and the renal vasoconstriction will lead to the hepatorenal syndrome. So patient will be presented with the less frequency of the urination and low urine output. And the last one is the hepatocellular carcinoma. So for the hepatocellular carcinoma, when there is no underlying causes like antifibrotic drug or cellular therapy given, a normal liver can progress to early fibrosis and cirrhosis, and the final will end up with the liver transplantation or hepatocellular carcinoma. So liver cirrhosis will increase chance of developing of liver cancer. So if patient have liver cancer, patient will have loss of weight, anorexia, fever, right hypochondriac pain, and also ascites. Okay, I think that's all from me. Thank you.
Okay, Assalamualaikum and good morning to everyone. Okay, next I will present the investigation that we need to done in chronic liver disease. Okay, first, the investigation that we need to done is liver function test. It is blood test that used to help diagnose and monitor liver disease or damage by measuring the level of enzyme, protein, and other substance made by the liver. The indication for a liver function test, for example, is to distinguish the causes of jaundice, either caused by cholestasis or hepatocellular damage. For the purpose, we will more focus on ALT, AST, ALP, and GGT. Next, we also will use liver function test to test the liver synthetic function, and we will focus on albumin, prothrombin, and also bilirubin. Okay, next. Okay. This table show the several components that we test in the liver function test, which is ALT, AST, ALP, GGT, bilirubin, albumin, and prothrombin. We also show the normal values and abnormality. So you guys can read by your own the table, but I want to emphasize that in hepatocellular damage, the level of ALT and AST will be increased. And ALP also will be increased in hepatocellular damage, but we need to determine the origin of the damage because ALP also will be produced in the bone. So if we want to determine the origin, we will measuring the GGT. If GGT also increase, mean the damage is come from the liver. While for the synthetic function of the liver, we will look for bilirubin, albumin, and prothrombin. For hepatocellular damage, the serum bilirubin will be increased, albumin will decrease, and prothrombin will be increased. Okay, next. Next is full blood count, which is we use to evaluate a person red blood cell, white blood cell, and also platelet. This table shows the normal value, and you guys can read after this. Patient in chronic liver disease, we might see anemia because it can be occurred due to the bleeding. In patient with chronic liver disease also, we can see pancytopenia that occur due to hypersplenism due to portal hypertension, which is one of the complication of chronic liver disease that we explained before by presenter before. Okay, next. Next is autoimmune hepatitis. This test to diagnose the autoimmune hepatitis.
Summarize autoimmune because it's not so common.
Okay. Autoimmune hepatitis is is occur when our immune system attack the liver tissue and cause damage. It has two types, which is type 1 and also type 2. Type 1 is the most common one. So in making diagnosis of autoimmune hepatitis, we will carry out the serological test to detect the autoantibodies in our body. The tests are serum antinuclear antibody, ANA, anti-smooth muscle antibody, ASMA, and also liver kidney microsomal type 1, LK1 antibody. Okay, for the type 1, it will show positive finding in ANA test, which is it present 10% in the patient with type 1 autoimmune hepatitis, while another 80% will show positive finding in ASMA. And there is no positive finding in LKM1 antibody for the type 1 hepatitis. While for the type 2, it only show positive finding in liver kidney microsomal type 1 antibody. However, these two types share some similarity in other findings, which is the patient will come with increase in bilirubin, AST, ALT, and ALP. The patient also will have anemia, decreased white blood cell, and also platelet, and also has hypergammaglobulinemia. Okay, next. Okay, next is imaging test. It consists of X-ray, ultrasound, CT scan, and magnetic resonance imaging. From what I read, X-ray is rarely we use because insensitive for gallstone, but so it cannot be used to diagnose hepatobiliary disorder unless the gallstone are classified and large. While for the ultrasound, we can use to evaluate the size, shape, and also blood flow of the liver. It also the first line that we use to identify the gallstone, biliary obstruction, or thrombosis in the hepatic vasculature. We also use to distinguish the causes of the jaundice and also to detect the liver masses. Next is CT scan. It is very insensitive in early cirrhosis, but it can detect small population, especially combined with contrast injection. It also can detect fatty liver and increase hepatic density that occur with iron overload. While for MRI, it also insensitive in early cirrhosis, but it's superior to CT scan and ultrasound for diagnosing diffuse liver disorder. Okay, next. Next is liver biopsy, which is medical procedure in which small amount of liver tissue is surgically removed and be analyzed in the lab. This liver biopsy usually guided by ultrasound and CT scan. Liver biopsy function is to evaluate the disease, for example, cirrhosis. It also used to detect infection, inflammation, and also cancerous cell. It also used to see degree of inflammation and scarring of the liver. And we also used to determine whether the medicine is causing toxic effect on the liver. Okay, I will put some example of liver biopsy. The picture above show the fatty liver disease, and from the picture we can see small and large fat droplet. While for the picture below, it show the liver biopsy for hepatitis B virus infection, and from the liver biopsy we can see the ground glass cytoplasm. Okay, next. Okay, this test is serological marker that we use to in diagnosing HBV and also HCV. Okay, first we look the structure of HBV. It has 3 antigen. First is HBsAg, and which is stand for hepatitis B surface antigen. Second is HBCAG, stand for hepatitis B core antigen, and also it has HBeAg that stand for hepatitis B envelope antigen. You also have DNA polymerase and also HBV DNA. Okay, so in diagnosing HBV, we will use serological marker to measure the
How many
HBeAg.
more slides do you have?
One more.
Okay.
We also measure HBeAg, anti-HBs, anti-HBe, anti-HBg IgM, and also IgG. For this serological marker, it will show different finding in different phase. For example, in incubation, it show positive finding in HBeAg and also HBeAg. It show the presence of exposure to the infection, while for acute, it show positive finding in HBeAg, and also HBc IgM and also IgG. This indicate activation of immune response and also active infection. While for the recovery, it only show positive finding in anti-HBs and also anti-HB IgG. This indicate successful of immune response. Okay, next. Next is serological marker for hepatitis C virus. First, we look to the hepatitis C virus component. It has envelope that can trigger the immune response to produce antibody. We also have core antigen and also viral RNA. In diagnosed HCV, we will do the anti-HCV that stands for anti-hepatitis C virus antibody. It used to indicate exposure to HCV. It is very good screening test for HCV infection, but it cannot differentiate between active and also resolved infection because the antibody will remain positive even after the successful treatment and clearance of the HCV infection. In order to confirm, especially in active or resolved infection, we will do the HCV RNA that can detect and also measure the amount of HCV RNA. The positive test will indicate the presence of active viral replication, while the negative test will indicate successful HCV treatment. However, HCV RNA is costly, time-consuming, and require expertise. Okay, next. Okay, that's all from me. I pass to next presenter. Thank you.
Okay, good morning, doctor and fellow friends. I'll be presenting about the treatment for chronic liver disease. Next. Okay, we'll be starting with alcoholic liver disease first. We have a few stages, as we know. It starts with alcoholic fatty liver, followed by alcoholic hepatitis and liver cirrhosis. So to combat alcoholic liver disease, obviously the first step will be to abstain from alcohol. So for alcoholics, psychotherapy like brief psychiatric intervention or consultation can help. In some cases, they can even be given pharmacological support. Okay. Another thing that we have to understand is that in patients with alcoholic liver disease is that the body tends to substitute calories they need from alcohol instead of food. So this will cause malnutrition in the patients. This makes nutritional therapy absolutely vital too. In regards to the abstinence, patients who take alcohol daily and then suddenly stop the intake, they may face alcohol withdrawal syndrome. Okay, they may have tremors, fatigue, anxiety, and worst cases, there even may be hallucination and seizures. So to help them combat this symptom or syndrome, medications such as benzodiazepines and thiamine, vitamin B1 can be given. Okay. Other than that, based on the patient's state of disease progression, general management can also be provided, like fluid therapy, electrolytes like magnesium, vitamins, and even consideration for admission. So based on this diagram, I think we can say that one of our main goals for treatment is obviously to avoid complications and to establish abstinence of alcohol and maintain the abstinence, followed by stabilizing liver function. Okay, next. Okay, yeah, so this is basically a summary of before. I'd just like to add that on regards to the pharmacological treatment, we have corticosteroids, prednisolone to be precise, because corticosteroids can actually help by decreasing inflammation by reducing the transcription of pro-inflammatory cytokines. Okay, so they reduce inflammation of the liver. Okay, next is pentoxifylline, which is mostly given to patients who are contraindicated for corticosteroid therapy. What it will do is that it actually inhibits phosphodiesterase, resulting in the inhibition of cytokine expression and macrophage inflammatory proteins, essentially also reducing the inflammation of the liver. Okay. Of course, then we have non-pharmacological treatment. I'd just like to add that in regards to the abstinence from alcohol, the drugs that are used to support patient or help them overcome the addiction are examples like baclofen, acamprosate, naltrexone, and of course the psychotherapy that we've talked about. Okay, next. Okay, so we'll be moving on to the non-alcoholic liver disease. So we can look at the diagram on our right, which is actually a stage-based management. We have the early stage of a non-alcoholic fatty liver disease with steatosis alone, followed by non-alcoholic steatohepatitis from stage 1 to 3 fibrosis, followed by non-alcoholic steatohepatitis with cirrhosis. So one of the main treatment is lifestyle intervention, such as diet and exercising at least 3 times per week, okay, losing weight and also avoiding alcohol in the diet. Okay, even though this is a non-alcoholic liver disease, consumption of alcohol can further worsen the condition of the liver. In some cases, bariatric surgery can be considered too, because it's a form of surgery to lose weight. Okay. In regards to pharmacotherapy, we can give antioxidants like vitamin E, because antioxidants can potentially protect cellular structures against oxidative stress that result in lipid peroxidation. Okay, next is pentoxifylline, as we've discussed before, and also insulin sensitizers, because accumulation of the fat in the liver can cause the organ to become less responsive to insulin. Okay, that can cause increased glucose in the blood and even type 2 diabetes in some cases. So that is why insulin sensitizers are given in this case to help combat insulin resistance. Okay, there are also other therapies in development such as obeticholic acid and JFT505, but all these are still in development. Okay, finally, it's also important to monitor for complications of non-alcoholic liver disease in severe cases such as hepatocellular carcinoma and also esophageal varices. Okay, next. Okay, so we'll be discussing about the management for chronic hepatitis B. So one of the main goals for treatment is to prevent hepatic decomposition, to prevent liver failure cirrhosis, and to reduce risk of hepatocellular carcinoma by suppressing hepatitis B virus replication. All right, so as you can see the diagram on the right, this is from WHO. So if patient is hepatitis B surface antigen positive, or is written here HBsAg positive, it is important to determine if they are cirrhosis based on their clinical criteria or based on non-invasive tests like the APRI score, which is the aspartate aminotransferase to platelet ratio index, or FibroScan, which measures the liver stiffness in relation to the liver fibrosis and so on. So if patient doesn't have cirrhosis and are age 30 and below, with persistent or intermittently normal ALT levels, treatment can be deferred. Okay, we will just continue with normal monitoring. But if the patient is above 30 years old with abnormal ALT, it's important to check for their HPV DNA level, which is the viral load for hepatitis B virus. Okay, and if it's less than 20,000 units per milliliter, then treatment is not needed. But if patient has cirrhosis or patient with DNA level of more than 20,000 units per milliliter, then therapy should be initiated. Okay, therapy mentioned here is the tenofovir and entecavir, okay, which are basically antiviral agents. Okay, and entecavir is indicated for children aged 2 to 11 years old. Okay, so treatment can be stopped if obviously if patient has no cirrhosis with presence of HBe antibodies, which is actually produced by our own body. And also the HPV DNA viral load should be undetectable with undetectable hepatitis B E antigen as well. So then we can stop treatment. Okay, next. Okay, so basically these are the drugs given in the treatment therapy. We have interferons and nucleotide analogs. So we've mentioned entecavir and tenofovir before. They are basically direct antiviral and they have direct antiviral effect. Okay, for interferons, we have conventional interferon alpha and pegylated interferon alpha 2A, which has both an antiviral effect and also an immunomodulatory effect. Okay, basically what this means is that you can use our immune system or regulate the immune system against hepatitis C virus. Okay, for example, okay, pegylated interferon can actually enhance interaction between APC cells to CD4 T cells and also between CD8 T cells and infected hepatocytes. Okay, this has a potential for immune-mediated HBV infection control and provides an opportunity for to obtain a sustained virological response post-treatment. Okay, in regards to its antiviral properties, it can actually induce activation of at least 40 cellular genes, okay, that encode antiviral proteins. And what these antiviral proteins do is that they can suppress hepatitis B virus budding, its entry, and also the synthesis of its nucleocapsid. Okay, next. Okay, finally, we have the chronic hepatitis C infection management. So one of the main goals is obviously to achieve a sustained virological response, which means an absence or undetectable levels of hepatitis C virus in the blood. So basically, this is to stop progression of active liver disease and to prevent development of hepatocellular carcinoma. Okay, we have non-pharmacological treatment and pharmacological treatment. In terms of non-pharmacological treatment, hepatitis C virus infected patients should be counseled on the importance of achieving and maintaining a good sustained virological response. Okay, it's mostly a multidisciplinary approach. So you have a lot of other disciplines involved like clinicians, pharmacists, dietitians, nurses, counselors. Okay, what they do is they can give education on hepatitis C virus, which includes telling the patient to abstain from alcohol because it can potentially worsen their condition, and also maybe educate them on the present risk of transmission of this virus to others through sexual intercourse. Okay, followed by monitoring services and also peer-based support. For pharmacological treatment, hepatitis C patients with confirmed viremia should be considered for direct antiviral agent therapy or treatment, but it's not for those with limited life expectancy or those with significant non-liver related comorbidities. So usually they are initiated with direct antiviral agents within a year. Okay, what is SVR12? SVR12 is a sustained virological response that is defined as undetectable levels of hepatitis C virus, okay, which is our HCV RNA level, post 12 weeks of stopping the treatment. Okay, this can actually be considered a cure to hepatitis C infection, right? And HVR24, on the other hand, is defined as undetectable hepatitis C core antigen post 24 weeks of stopping treatment. And this can be considered an alternative endpoint or can be used as an indication to stop as a cure, okay, if HCV RNA assays are not available or if it's not affordable at the time. Okay, next. Right, so we spoke about direct antiviral agents. So these are the list of the DAAS. We have NS3-4A protease inhibitors that usually work by blocking viral enzyme protease that the virus needs to replicate and survive. Okay, and NS5A inhibitors, they will block a protein called NS5A that is needed for the virus in RNA replication. Okay, third one is non-nucleoside NS5P polymerase inhibitors. They work by inserting themselves into the virus so that other pieces of hepatitis C cannot attach to it. And finally, the nucleoside and nucleotide NS5P polymerase inhibitors that inhibit the action of RNA-dependent RNA polymerase that is needed in RNA replication. We have on the bottom left, we have a small algorithm. It's actually a hepatitis C infection in patients with chronic kidney disease based on this chronic kidney disease staging in regards to GFR. There's actually a strong connection between chronic kidney disease and hepatitis C because a lot of chronic kidney disease patients, they get infected with hepatitis C through their treatment like dialysis and so on. Okay. Another thing that I like to add is the number that you see in the brackets are actually the genotype for the hepatitis C virus. Right, okay, I think that's all. Next. Right, that is all from us. So if you have any questions, you can ask us. Yes, thank you.
Okay, can you hear me? Hello, can you hear me?
Yes, doctor.
Okay, do you have any question from to the presenters first from the group? No question? Everybody clear on the chronic liver disease, common cause, hepatitis B, hepatitis C, alcohol, and fatty liver. Hello? Everybody clear?
I want to ask question regarding fatty liver. How to differentiate the appearance of non-fatty and appearance of alcoholic and non-alcoholic fatty liver?
Okay. The only way to differentiate is to do biopsy, liver biopsy. However, in current practice, we do not proceed with liver biopsy, even in viral hepatitis B or C. So for currently, management has changed. We are now moving towards non-invasive modalities to assess the liver uh, damage. So what we do is usually we do um, a test called fibroscan. Fibroscan is an ultrasound that measure the elasticity of your liver. So the elasticity is an indirect way to measure your impedance or the fibrosis of your liver. So a normal liver will be elastic, will be firm and elastic. A cirrhotic liver will be stiff and not elastic anymore because it's fibrotic. So the fibroscan measure the score of elasticity. So that's an indirect way to know the severity of uh, liver disease in the patient. And this fibroscan can be used for all condition. Can be used for hepatitis B, hepatitis C, alcohol can also be used for fatty liver, and can also be used for other, for example, autoimmune. So that's where we are moving now, the current practice. So we don't do no more liver biopsy. Even when you suspect patient as having hepatitis, hepatocellular carcinoma, malignancy, you don't biopsy. Okay, you don't biopsy. You just use non-invasive method, for example, CT scan with contrast or MRI to confirm the diagnosis. Okay. Any other question? Okay. If there's no question, thank you to the presenters. It's quite a good presentation. I'm quite satisfied. And we can stop and end our session here. Thank you very much.
Thank you, Doctor.